Well, welcome everyone to the Eastside Freedom Library. I'm Peter Ratcliffe, the co-executive director. This evening, I'm sitting in for my colleague Clarence White, who was instrumental in putting this program together. What we're doing this evening is exploring a reform of the healthcare system, engaging a new book, the book Why We Revolt, and its author, Victor Montori. And Dr. Montori came to us through the advice and intervention of our old friend, David Unowski, who many of us know as the founder and longtime manager of the Hungry Mind bookstore, which he ran for 34 years. And David is still, I guess we could say David's become a kind of eminence grise in the literary world in the Twin Cities. And we're so thankful that he brought Dr. Montori to us tonight. What we've been trying to do at the Eastside Freedom Library when we have a chance to bring an author into engagement with our community is we try to invite a couple of interesting people to read that author's book and offer some insight and engagement before we go to a more open discussion. And so David is going to introduce Dr. Montori, but I want to take the pleasure to introduce our panelists. They are State Senator John Marty, who has long been a voice for healthcare for all and healthcare reform here in Minnesota. Rose Roach, who is the executive director of the Minnesota Nurses Association and a great voice within the labor movement and the healthcare industry. And Jigme Ugin, who is the vice president of SEIU Healthcare Minnesota, the first Tibetan refugee to hold a major position in an American union. And Jigme has been active in both the community and the labor movement. We're delighted that he and John and Rose could take the time tonight to join with us. Our plan is to ask you, the audience, to use your comment or chat function, whether you're on the Zoom connection or the Facebook page. When and if you have questions or comments, please type them in. My colleague Carla Reilly, who is handling the tech for this program and is an extraordinary collaborator with the Eastside Freedom Library, Carla and I will be trying to gather your questions so that the panelists don't need to be keeping one eye on the questions and one eye on what they're thinking. We're going to try to do the one eye on the questions for them, and we'll bring the questions forward. So that's the plan. Let me turn things over to David Unowski, who is going to introduce Dr. Montori and then moderate the discussion. And I'm going to turn myself into a logo. David.
Thank you very much, Peter. This discussion is prompted by this book, Why We Revolt, A Patient Revolution for Careful and Kind Care, written by Dr. Victor Montori, published by Mayo Clinic Press. Proceeds from the book go to Victor's organization, patientrevolution.org. You can look up their website after this discussion and you'll find a lot more good information. Books are for sale by our book selling partner, Subtext Books, and there should be a link somewhere. If not, you can go right to Subtext Books and order the book. I'd like to introduce Victor. Victor Montori works at Mayo Clinic Press in Rochester. He's a diabetes doctor. He graduated medical school in his hometown of Lima, Peru, completed postgraduate work at Mayo Clinic in the US and at McMaster University in Canada. He's considered a patient's doctor. He won the Caris Award, a patient-nominated recognition for his compassionate care. He's a researcher in the science of patient-centered care. He and his colleagues have authored over 650 research articles. He was a full professor by age 39, and he's one of the most cited clinical researchers in the medical world. In 2016, he founded the Patient Revolution, and he's going to do a little reading from his book and talk about it, and then we'll hear from the other panelists. Please welcome Victor.
Thank you, David, and thanks everyone who's joined us today here on the Zoom and also on Facebook Live. It's a wonderful honor and a very humbling opportunity to spend these hours in the night here together. It's difficult to choose what to share about Why We Revolt, although it's a thin book. It's not like it's not like a big tome or anything. It does have perhaps two different voices in it. One that is a commentary, an essay really about what healthcare is and ought to be. And another one, which is a series of stories and the descriptions of that situation and the situation we want to go to. I've chosen some passages on the commentary side, and if we get the time, I may sneak in some of the other types of stuff and give you a flavor of what the book's tone is, and perhaps the panelists may comment on this as well. For those of you who are fans of this, the first two words in the book are George Orwell. Not entirely sure how I made that choice, but that's what it turned out. And I talk about this book being documenting my sense of what is wrong about industrial healthcare. Industrial healthcare fails to notice patients. It standardizes practices for patients like this, rather than caring for this patient. Efficient specialization and narrow job definitions drive industrial healthcare's focus towards organs, diseases, or test results. Rigid protocols and fear of deviating from them miss the person. Systems that prioritize access and volume place very little value on the length and depth of the interaction between patients and clinicians. Forcing encounters to be brief and shallow speeds patients through consultations in which clinicians cannot appreciate their patients' situations fully. Failure to notice is also the effect of encounters bloated with industrial agendas, such as documentation and billing, which draw attention away from patients and toward the computer monitor, distracting from care to document it. How does care then take place when the patient is unnoticed, sometimes little more than a blur? Judging from the stories that clinicians and patients tell, care happens almost by mistake when someone takes exception to or ignores the protocols. In the absence of these accidents, of these caring mistakes, the industry is capable of harm through unintentional cruelty. As it makes care accidental and cruelty incidental, industrial healthcare marches on to produce fortune and power. By focusing on its industrial goals, healthcare forgoes caring. The harm is done not only to patients. Industrial healthcare is killing the healer's soul. Enforced productivity depletes clinicians, and clinicians is the term that I use throughout the book to describe anyone with the privilege of the bedside. Industrial healthcare is killing the healer's soul. Under efficiency pressures, clinicians cannot draw meaning from fleeting patient visits. They cannot get support from sped-up colleagues. They feel abused and without love and unable to love. Burnout, divorce, and suicide become inherent to the work of healthcare, the healer's curse. Industrial healthcare has stopped caring for both patients and clinicians, for everyone at the front line. Many of my patients, my family, and I have benefited greatly from the wonders of modern healthcare: expert surgical teams, clean and efficient facilities with all the necessary equipment, carefully organized services that collaborate and coordinate, well-trained professionals who cordially attend to those who are sick and invest each one with dignity. All this is possible. It happens, just not routinely or by default. This is the should be that I have the great fortune of enjoying on the good days. On the bad days, this should be lurks between tightly scheduled slots in the furtive half smile of another clinician rushing to the next patient, in the sigh of the staff who had hoped to give more prompt service. It screams from the notes I get from family members or their friends asking for a second opinion or telling their stories, some of them horrific tales of perfect medicine for the wrong person or for the wrong problem. It pulls at my heart when I see what has happened to the patient in front of me. Files filled with test and procedure result, 12 medications, multiple specialties, and notes that reveal no one ever stopped to notice. On many days, I am afraid I am that clinician, that cog of the machine, the one who fails to notice. Simply noticing and acting on what is noticed makes patients more likely to receive care that makes intellectual, emotional, and practical sense to them, care that responds to their needs and is consistent with their views of the world and their lives. This is care that recognizes and respects that patients may need to devote their scarce time, energy, and attention to matters that compete in priority with the administrative and self-care tasks healthcare has delegated to patients. This is care that responds with competence, science, creativity, and humanity to advance each patient's situation without overwhelming patients or creating new ills. And I mentioned that in the chapters of the book, I was hoping that those chapters will ignite in you, the reader, the urgent need to join us in destroying the difference between what is and what should be, in abolishing accidental care and incidental cruelty, in making care the intentional end of our work, not the means to achieve industrial goals, in ensuring our best medicine reaches everyone who needs it. Clinicians and anyone honored by the possibility to care must notice each person in need of their care and act in response. They must appreciate each person's circumstance, concerns, context, biology, and biography. To appreciate each patient, the clinician must throw moorings that, for a moment, partner the boats. Traversing rough waters unhurriedly, elegantly, together, patient and clinician can, with compassion and competence, co-create a trajectory that advances the patient's particular situation. Such careful and kind care for all must be the end result of a patient revolution. This is read from the introduction of the book. I'm going to connect that with the epilogue of the book, so you get a sense. You probably feel like you just read the whole thing if I just mentioned this little thing. Reclaiming patient care as a priority of healthcare organizations and of clinicians is our goal. We want elegant care in which clinicians are present and able to notice each patient and appreciate their human situation in high definition. We recognize that it all requires innovations to achieve careful and kind care. A system of patient care oriented by solidarity and not by greed will be necessary to prevent precious resources from leaving the system as profits, artificially creating scarcity. One of the ways we will know we have arrived is when the polarity of the healthcare world inverts, when policymakers, payers, and managers are held accountable to clinicians and patients, when they see their work as ensuring patient care without disruptions, distractions, or extraneous exertions, when they see patient situations in high definition and work with patients to ensure their care makes sense to them. Today, managers use quality and performance measures to judge clinical care and to document to payers that clinical care is a good value for the money. When the polarity inverts, we will be holding managers and funders accountable for creating and fostering innovative and sustainable systems that allow patient care to happen routinely while avoiding incidental cruelty. The flow of value will be turned on its head, with every resource dedicated to caring for all. We must confront the apparent policy choice before us. Some believe in a profit-based competition-fueled system that overserves affluent patients and underserves everyone else. They value this system because they believe it is capable of driving the flourishing of important innovations in care. Others believe that social justice is preferable, guaranteeing universal access to healthcare as one of the ways in which societies advance their citizens' health as a fundamental right and their capability for their personal flourishing. As with many dichotomies, this may be a false one. A patient revolution must promote new thinking to uncover the ways in which social justice, innovation, and sustainability should not be traded off, but be a joint expectation of any system built on developing value for patients. Nothing else can satisfy our goal of careful and kind care for all. None of these shifts will take place spontaneously. In fact, my reading of the forces at play is that they continue to lean heavily toward industrial healthcare. So, can citizens and professionals change this situation? I have chosen to speak of a revolution because reform is not enough. It is time for patient revolution, not only because it has patient care as its goal, but also because I believe citizens, healthy people, patients who are not too sick to mobilize, must lead the way. I believe clinicians will join soon, while others will follow later as they free themselves from the corporate shackles, relinquish the spoils of industrial healthcare, recover their faith, and start believing in our probable success. And it's about probable success that I wrote the new preface to the book, in which I touch on the COVID pandemic, because I think it offers us hope. I write the second edition of this book to coincide with a global disaster. A pandemic of febrile breathlessness has galloped into our lives along with fear, disinformation, and isolation. To outsmart the virus, we have to stay away from each other. At the moment of this writing, the virus has decimated the closeness, the kiss, the handshake, the hug, the presence, the touch. This pandemic, however, is like an urban redevelopment that accidentally unearths ancient ruins, revealing something new about our present selves. COVID-19 has made evident our core humanity, the care in our hearts and in our hands. To outsmart the virus, we had to be apart, but we reduced social distancing to physical distancing, and solidarity took hold. We found ways to sing from apartment windows and rooftops, to play bingo from across the street with lonely and frightened nursing home residents, to leave gift boxes for waste collectors, to build tents on bullfighting arenas, to house the homeless, and to come together to ensure everyone had a meal. We sent poems, cards, letters, and notes to strangers and to estranged friends and relatives. The world slowed down and families experienced conversation of the unhurried type. Clinicians responded to the privilege of the bedside by showing up and caring, despite the risk of contagion. They reached out to patients with ongoing conditions, those pushed away by overwhelmed hospitals, and cared for them where they were, minimally disrupting their lives. Communities turned toward caring for each other. The care of patients became more careful and kind. Our revolution was validated. Its goals became feasible, existing here, now. We must not forget this. Industrial healthcare, as this book describes, long ago stopped caring. The pandemic simply exposed with even more clarity the corruption of its mission. National and corporate leaders make the same calculations as did opportunists and profiteers. Getting more ventilators was too expensive, and a breathless elderly person asked his clinician to save the available ventilator for the breathless young person. Masks and other protective equipment were made scarce and expensive, and exposure to the coronavirus increased unnecessarily. Because of this, an exhausted clinician returned home to sleep in the basement, quarantined from her small children. Their distant giggles were made to seem closer by her phone, her kisses pushed against the hard surface of the screen. Because of this, visitors were kept outside of hospitals and nursing homes, and those inside were left to suffer without a hand to hold and to die alone. Eventually, we will become immune to the virus. Then the smiles will appear from behind their masks, handshakes will become ungloved, and hugs tightened. With fraternity no longer the vector, we will learn to trust the air between us, and we will touch again. The singers will descend from their balconies and rooftops onto our plazas to sing song of togetherness. The lonely will be touched, the scared will be relieved. But then we will wake up. Most likely, this new day will not find us hugging or singing with strangers, but conducting our business as usual. The post-pandemic economic crisis will argue urgently for deepening the industrialization of healthcare, for making healthcare more efficient, standardized, automatic, artificial, and generic, more profitable, less caring, a better reflection of a society of people who, mobilized for productivity, will quickly forget how solidarity carried them through the long night. Once again, a dawn of care, kindness, and love will seem poetic, utopic. This book argues for a different day after. Not a day for celebration, because the old normal of cruelty and greed are ready to make this day their own. Rather, a day, improbable but no longer impossible, in which we will recognize in each other the scars of that long night, a reminder of a common fate, a date in which we will remember that our human business is to care for and about each other. We will remember that we have done this before, and we will remember the songs. And at daybreak, we will revolt for careful and kind care for all.
Thank you, Victor. I'm going to ask John Marty to respond. John is a state senator. He is the author of the proposed Minnesota health plan, which would replace the health care system, the insurance system, with health care for all to keep people healthy and enable them to get the care they need. John, what do you have to say today?
Thank you, David. And when Clarence sent me this book, which I had not heard of until he sent it and asked to participate in this, I didn't know what to expect. I figured, well, if he was sending it to me, maybe it was about healthcare policy. And in many ways, as one who's been a long-time advocate for universal healthcare to cover everyone and to have a better society, it's not just replacing the payment system in a way to ensure everybody gets care, to make sure they get good care. And our healthcare system, when I say people, I care about good, high quality care for everyone, keep thinking all the reform we've done for the last 30 or 40 years, either to save money, which usually costs more. We've been doing that for 40 years, and it's going to improve quality. And some of our quality measures are killing people. I mean, literally, and they are at a minimum taking doctor and nurse time away from the patient in order to fill out forms. And it's done is, I haven't used the term industrial healthcare the way Victor does, but it's a perfect term for it because the people in charge of it, they know what an efficient business is and how we're going to do it. And they're trying to make healthcare instead of a caring enterprise into a business. And so they think, I was going to read a couple of sentences from his book when he talks about greed. Some people believe the only reason medicine moves forward is money. Competition and profits drive innovation. They believe that money motivates brilliant people to go into basic science to discover cures. It's what makes people study medicine, nursing, therapy, or pharmacy. It's what keeps clinicians up at night on call, or compels them to jump onto a helicopter amid a storm to retrieve a donated organ for transplantation. I don't think so. Those are the words I'm going to end his quote with. He says, I don't think so. And I think we recognize the importance of that. It's about caring for people. And every time the reform of the last 30 or 40 years tries to do it, well, we got to make it more affordable. So how are we going to do that? Well, if we get these accountants in here and we get these bookkeepers and lawyers in here, we'll find a way to squeeze a little more efficiency out of the people working at the bedside. You know, the thing you need around the bedside, which I think the book was so articulate in saying, is time. You need to be able to listen to people. And when you see doctors and nurses' time taken away from it to fill out forms for billing and everything else, you know we're going the wrong direction. Same thing happens with the quality of care. Instead of using the doctor's judgment and everything else, we're going to have them check these boxes, which takes away their mindset of thinking about things. Instead, have I done this? Have I done this? Have I done this? And the idea that doctors or nurses are going to provide better care, they're going to work harder because they're paid more for it, is bizarre. Yeah, people want to be paid more. Everybody wants to. And some people deserve to be paid more, a lot more. But the idea that somebody is going to replace that doctors aren't doing this and nurses aren't doing this because they care about the outcome of their patients, but only that they get more money. If you start with that premise, you're robbing those other values that we want to do. That I'm a professional, I want to do a good job for people. I want to make it look good. So we forget all of that and all in the favor of greed. I'm going to quickly point out two other things that really hit me. One is a theme he pointed out numerous times in the book about how we blame the patients. And page 83, I had marked, he has a patient named John, an archetypal patient. And he talks about how blaming the patients is like blaming the canary in the coal mine. They're the ones who are hurting, and we expect the patients. We want more little skin in the game. And somehow, if the patient works harder at it, they're going to care more about their health. These are people who are desperate already and struggling. And I just thought he captured so well the importance of taking care of others. And the third one was about when he was talking in his solidarity section and how we're using the money to make it more efficient. He talks about the big bucks are paid to creative, insightful, and decisive executives who are tasked with making healthcare sustainable and innovative. It is neither creative nor insightful to eliminate less profitable services and exclude or waitlist patients whose care hurts economic performance. And yet all of our reforms to improve quality are doing that. You look at the analysis of the pay for performance schemes, the quality measures, and they always punish the low-income clinics. They always punish the safety net hospitals because their patients have worse outcomes. And that's a bizarre way to do it, but that's the way we've been headed in our reforms in so many years. And when I look at that, if you want a concrete example, St. Joe's Hospital in St. Paul, I think it's the oldest hospital in the state. It certainly cares for a lot of the neediest people who are struggling with addiction or struggling with mental health issues. And Fairview, Health Fairview, whatever they're called now, is closing it down because they're losing money on them. I've written several letters trying to protest it with the board and trying to change the law so we can't allow them to transfer those beds to other more profitable areas unless they're going to replace them with mental health or addiction beds. But they don't want to do that. And why don't we change it? I mean, even if they were a greedy healthcare system that wants to get rid of its least profitable areas, why don't they come to the state and say, look, maybe you're overpaying some folks for some surgical procedures. Maybe you should take some money from there and pay more for the mental health beds. If we're losing money on that, why don't you try and change the system? Instead, they don't want to deal with it. They just don't care. And so to me, our healthcare system is very sick. And exactly when he described, and he said it in his presentation, we want a caring and kind system. And that's all we need. That's all patients want. And I think there's so many people, so many doctors and nurses and healthcare workers who want to do that. And yet the healthcare system knows that, nope, everybody works on greed and only on greed. And therefore, we're going to have to squeeze every drop of blood out of them, even if it means taking time away from doing their jobs so they can fill out our forms. So I want to thank you, Victor. If we are trying to, in like my legislation, if we're trying to map out a route for where we go with healthcare reform, your book and your work is the soul of what we're trying to do and why. So thank you.
Thank you, John. And remind everyone that they can submit questions on Zoom and the chat function or on the comment space on Facebook. Our next responder is Rose Verwich. Rose is the Executive Director of the Minnesota Nurses Association. She's been recognized as one of the 100 most influential people in Minnesota in healthcare and is on the board of Healthcare for All Minnesotans. Rose?
Thank you. Good evening, fellow patients. Dr. Montori, esteemed fellow panelists, and the incredible staff of the Eastside Freedom Library. Greetings of health from your nurses. Victor, thank you so much for this important, inspirational book. It is clear, doctor, that you get it. You, like nurses, clearly understand healthcare, that it's about centering the patient, their needs, their care. In the book, you state, quote, healthcare has shifted its focus from patient care and instead has honed in on achieving goals that are industrial and financial. The nurses couldn't agree more. It's the very essence of the healthcare system problem. We simply must reduce the burdens to care for providers to allow for more, as you say, listening and kindness, while removing barriers to care for patients, and that barrier is overwhelmingly tied to the cost of care. I'd like to highlight a couple other salient points that you've made about the cruelty of our system, which I prefer to refer to as our healthcare marketplace. And it's actually the first quote I chose. You read about the post-pandemic economic crisis we're in, but it's always good to repeat, right? So I'm going to reread the portion of that quote because I think it's so powerful. The post-pandemic economic crisis will argue urgently for deepening the industrialization of healthcare, for making healthcare more efficient, standardized, automatic, artificial, and generic, more profitable, less caring, a better reflection of a society of people who, mobilized for productivity, will quickly forget how solidarity carried them through the long night. Once again, a dawn of care, kindness, and love will seem poetic, utopic. The de-skilling of the healthcare professions and the depersonalization of healthcare itself has been in play for some time now. The pandemic has created this environment that is allowing industrialized healthcare to say, see, we can provide you care without even seeing you in person. Telemedicine, hospital room cameras being monitored by someone off-site, even nurse robots. We simply cannot go down this path. We must redirect the delivery of care from being mechanical to becoming intentional, thoughtful, and based on the foundational relationship between caregiver and patient. You also noted industrial healthcare is killing the healer's soul. Industrial healthcare has stopped caring for both patients and clinicians, everyone at the front line. So very true. Nurses are deeply concerned about what they refer to as chart, taking them away from the bedside and patient care, and instead putting them in front of a computer that is more about coding for billing purposes than it is for patient health outcomes. Nurses speak to the moral injury they suffer daily at the hands of industrial healthcare, lack of necessary staffing to properly care for patients based on acuity needs, lack of preparedness related to the pandemic, specifically around personal protective equipment, procedures for safe care like cohorting of COVID positive and negative patients, lack of testing of employees, while claiming at the same time that nurses who become infected were most likely to have been infected through communal spread, even though the hospitals, in many cases, are still not providing proper safety equipment and protocols for the nurses and frontline workers and doctors who are working directly with COVID patients. It's clear to the nurses that it is, in fact, the doctors, nurses, and frontline healthcare workers that need to be steering the healthcare ship, and we're very appreciative for the eloquent way in which your book makes that obvious. For decades, the nurses have been leading the healthcare justice movement to dismantle the industrialization of healthcare and to rebuild a healthcare system that's all about caring, because nursing is about caring. Your book, Doctor, lays out the roadmap for the what? A healthcare system that, as you say, is, quote, fueled by greed, excluding millions from care, consumes more resources, and produces worse health outcomes, compounds its limitations, your money or your life. As it also lays out the why. These, as you say, these industrial actors satisfied their greed by promoting maximal healthcare spending. Yet there are other actors, such as insurers and other payers, who satisfy their greed by promoting minimal healthcare spending. The patient is caught between these two, seduced by the former, frustrated by the latter. The nurses see it the exact same way. It is why we have launched a national campaign to implement Medicare for All, and in Minnesota to enact Senator Marty's Minnesota Health Plan, both single-payer healthcare systems. At its base level, single payer is about simplicity of the healthcare financing system, but at its heart, it is about changing how we actually deliver care. At the end of the book, you offer 2 steps that we can take to bring a patient revolution that will be required to achieve the system we all need and deserve. You say, first, stop accepting healthcare as an industry and your healthcare as its product. Yes, yes, yes. Healthcare is not a consumable good. It is a Don't decide to have a coronary bypass one day because Alina has a discount on that particular procedure. It doesn't work that way in healthcare. Second, you say start a conversation. Use the language of patient care, some of which we have explored here. I trust that our cause is just and that we can change the way people think and act with our words. Our cause is just. Our movement is growing, and our struggle to win the recognition of healthcare as a human right is on the horizon. Thank you again for this amazing work, Victor. We'd love to find ways to partner with you and your organization, The Patient Revolution, because together we can and will change our healthcare world for the better. Thank you.
Thank you, Rose. Next person is Jigme Ugan. He was born in Kalimpong, India, graduated from Delhi University. He's got diplomas in political science, English, and economics. He's the first Tibetan refugee to be elected as a labor union leader, and he is the vice president of SEIU Healthcare Minnesota. Jigme?
Thank you, David. And what an amazing discussion here. Real, honest, and all coming out of this book. So, Dr. Victor, thank you. And folks who are watching this, you need to go buy this book. I would say this is the Da Vinci Code of healthcare books. So Victor would be Dan Brown of writing about it. It's got suspense, it's got drama, it's got reality, it's got some really like, you know, some tear joking, some like triggering and frustrating moments, the reality of what healthcare is in this country. Sister Rose already pulled on my favorite quote here, which kind of brings to the focus of what Victor is trying to say here, which is stop accepting healthcare as an industry and your healthcare as a product. That defines the American healthcare system. And then there's this piece where you write about that the patient revolution must reject the notion that time is money, or that a minute, like a dollar, can be easily exchanged for another minute. These really hit me hard, right? And folks who are going to read this book, there's a lot of stories that Victor brings in from Peru. And it really hit me, I mean, personally, because like David said, I was born in Kalimpong. It's a small town in the foothills of the Himalayas. You know, for the 30 years that I lived there, never once did I experience a situation where cricket, Bollywood, or religion became secondary issue to healthcare, right? I mean, living in India where you have 1.3 billion people and they have a free public healthcare. I'm not saying that they have the best healthcare industry, but they have the cheapest medication, right? And this is what the book talks about too. And when I talk about cheap medication, the cost of surgery in India is about 1/10 of that of the US or Western Europe. I know so many healthcare workers who have immigrated from India who go back for major surgeries, dental work, or even for prescription glasses. And now we are in the richest country in the world, where living debt-free and bankruptcy is but one serious illness and one medical bill away. So when we talk about healthcare, which is beautiful, and I'm going to keep holding this because like I read this book and then I went back and marked a lot more, and it's going to be a reference for me. You know, the kindness and the compassion piece that is lost in healthcare, right? The reality of healthcare being a human right is far removed as we move into it. You know, here, when we look at Minnesota, except for, I mean, Regency Hospital and Prairie Care, Minnesota has not nonprofit or government-owned tax-exempt status and charitable mission for hospitals with the sole goal and intention of providing quality care for patients. And as Senator Marty talked about, St. Joe's, the closure of St. Joe's, the closure of Bethesda, the only COVID center being closed and then converted into a homeless shelter so that the workers there, really, you are in a rock and a hard place. You cannot even fight it, right? And that's what it goes back to when you talk about the industry. It's not just the industry, it's the system, right? When we talk about, and the book really talks about when the COVID hit, on the other side, right, when I was talking to our members, now our members are in hospitals, in nursing homes, clinics, long-term care, home care across the state. They were fighting for PPEs. They were fighting for masks, right? But they did not stop going to work a single day. Today, they are negotiating with these employers who have completely forgotten and are actually treating these workers like you should be happy that you have a job, right? The whole concept of hero pay, it was just words, right? Nobody were given a hero's worth. So this COVID actually opened up a lot of things that we had, like it's there, but it's now more real. Our workers are seeing it real. The employers who stayed at home while our members were on the front line, the disparity is coming out more fluid. The piece that this book, one of the things that Victor, at some point I really want to talk about with you is the piece on racial disparity. You do touch on it a little bit, but for me as a person of color, I see this a lot. Now here in the state of Minnesota, we say it's the healthiest state, the best bike lanes in the country, but only if you're white. Right? Minnesota is still ranked the second worst in the country for racial inequality. Like compared to white people, members of racial and ethnic minorities are less likely to get preventive health services and often receive low quality services. And I was like doing similarities of what you saw in Peru. I was like, this is happening here. We are all just talking about the structural racism, which is like deeper into the society, right? COVID-19, again, hitting Blacks and other ethnic minorities created a new focus of racism in healthcare. And this is a pattern we've seen since AIDS, prenatal care, Black, Indigenous, and people of color, BIPOCs have been affected and have not received the right treatment. As an immigrant, I can say, right, and these are conversations that we have, we don't go to the hospital a lot for preventive care. It's only if we start bleeding and we see blood, we're like, oh, I think I need to go see the doctor. We call it the windshield wiper theory, right? You go to to get a windshield wiper fixed. By the time you leave the garage, you're walking out with a new radiator, right? So that is the fear in the healthcare system that people of color have. And it's just like one quick example that I wanted to talk about was, I was reading about this algorithm that helps manage healthcare for 200 million people. And they found that it was systematically, the computer was systematically discriminating against Black people. Now, the journal Science said that the people who were identified as Blacks were given lower risk scores by the computer than white patients, leading to few referrals for Medicare. So the algorithm was actually copying human behavior from the past, right? So when we look at this book, when we talk about the patient revolution, and as I think Sister Rose talked about it before we started the actual discussion about how we need to fight racial, climate, housing. If we do not succeed in any of these, we will not succeed in winning healthcare. They are so intertwined, and success of one is a success for another. So again, going back to this book, I really appreciate Victor, you giving us food for thought, bringing in concepts that, like I told you earlier, I wish we had more doctors like you who would be honest and real about care, about the compassion, about the work that goes in play. And I really appreciate you writing this, your thoughts, sharing it with us. And I really encourage people to buy a copy for your neighbor, buy a copy for someone who really doesn't understand healthcare, and keep an extra just in case. So thank you again, Victor.
Thank you very much. Something happened to my computer. I hope you can see me, but Peter, can you read some of the comments or questions?
Sure. Did you want to give Victor a chance to respond to the comments if he wanted?
Sure. Go ahead, Victor. Or go ahead and read them, and Victor, you can respond first.
No, I meant to the panelists.
Okay, go ahead.
Is
Sure.
but keep it short.
I'm just going to say I'm speechless, but then of course, then I'll keep talking and that will be a contradiction, wouldn't it? The generosity of all three of you is overwhelming to me. Um, I am very self-critical. And so of course I pick up Jigme's point, which is the book has a huge, huge, massive blind spot. And the blind spot that it has is that it didn't directly address one of the major carelessness of our society right now, which has to do with the issue of racial injustice. And I'm going to defend a little bit myself, only to say that when we speak about seeing the patient in high definition in biology and biography, that has led a colleague of mine to take that and begin to develop a new competency for clinicians, which she's calling situational literacy, in which it would allow these clinicians to begin to understand the experience of illness and of care in light not only of the biology of the patient and what might be happening in their own lifetime, but the centuries of discrimination and abuse that may be affecting both the experience of care, the access to care, and the care that they receive, very much in light to what Jigme has observed with the algorithm that had embedded in it some structural racism in it. So I think that that's one start. But with everything that we talk about in terms of care, and I will finish here, Peter, with anything we talk about in healthcare, we have to be careful that we cannot fix structural problems in society at the bedside. You know, we might want to do our best to try to minimize its impact and be aware of it so that we can construct care plans that make emotional, intellectual, and practical sense to people that account for those things. But the fight for a more careful society, one that cares for and about each other without discrimination as it cares for the planet, which Jigme also brought up, is actually a fight that needs to occur in the public, in the political sphere. And those of us that are called to care at the bedside must also be ready to be in that political sphere, in the public arena, arguing, articulating the case and advocating for care, not just in the professional space, but also in the public space.
Great. So let me remind everyone that if you have questions or comments, please use the chat here on Zoom or the comment function on Facebook. There are several questions and comments about the role of electronic medical records. As a labor historian, I'm struck by kind of the pattern of technology creates problems, and so we create more technology to solve the problems that have already been created. And I wonder if, Victor, you in particular, do you want to say something about the way the introduction of electronic medical records has not produced better quality care?
I wouldn't be as pessimistic. The electronic medical records are a natural evolution of our technology. It's crazy to be relying on unavailable pieces of paper that can only be approached physically. COVID has actually highlighted the value of having this in electronic format, which has allowed us to pivot to forms of care that did not require any of us to go into the office and look for the file to be able to understand what happened to the patient last week. There's evolution on that I think is in the right direction, allowing not only for those records to exist, but for patients to access them directly, and even the possibility of co-creating those records in the near future. I think there have been enormous distortions with their use associated with the spirit of their introduction and the spirit of industrial healthcare. In other words, once you introduce this tool, the way it is used, it reflects the values of those who direct its deployment and its use. So to the extent that it's used to document care, to support audits and support higher levels of billing, then it's no longer a document to for the clinician to remember what has been decided, to communicate that over time and with colleagues, and to help integrate and coordinate care, but rather a bloated set of piece of information, many times completely fictional, physical examinations of body parts that were not examined. You know, I usually in my presentations talk about Mrs. Jones' prostate. You know, it's some cut and paste go wrong, right? And so so we have to be careful. The tools in it themselves are, I think, for the most part, value neutral. It's their implementation and the spirit of of design of its features, the features that get highlighted, made easier to use, and so forth, that tell you what it is about. And when it's easier to cut and paste and bring parts and create bloated notes so that you can command higher levels of reimbursement, and you design the tool with clicks, so your eyes have to move away from the patient so you can click in the right place. And that's considered favorable because it makes a killing for the organization that invests in those records. That's what corrupts its purpose. And I think the intention, I mean, electronic medical records were a key component of the Affordable Care Act, and there were a lot of incentives for people to adopt them, and many people begrudgingly did so because the incentives were there, you know, it was very good. But it's modernity. It comes with the times. It makes it sustainable. It disrupts patients' ability. You know, how many times have you been waiting for a test result that tells you whether your cancer is back or not? And you call the office and the doctor doesn't return your call, and you're in anguish, when you can just go directly into your record and look for it yourself. And so, yeah, there might be some downsides to that, but fundamentally the opportunity to reduce anxiety and avoid the error of not following up on test results might be reduced. So I wouldn't be pessimistic about the tool. I would like to say that it is the context of industrial healthcare that makes everything, including something as electronic medical record, a potentially negative disruption, produce a negative disruption in care.
Peter, I would have
Please, John. Yes, go ahead.
I want to comment on this as well. And I'm glad the way Victor wrote that in the book about talking about how much time people spend on it and so on. In the comments, Alita Borud, who I'll mention is another medical doctor and was about 1,000 votes shy of becoming one of my Senate colleagues last November, and would have been a wonderful addition to the legislature. But she mentions in her comments, studies estimate up to 1/3 of hospital costs related to billing and coding. Mayo just spent more than $1 billion on a new electronic medical record to better capture revenue through billing and coding, but reduce the specificity and accuracy of provider-to-provider communication. That is, so I very much agree with what Victor is saying, but also, in other words, I wouldn't call it value neutral. I'd say it's a big plus in some ways, but the way it's being used is focused on how we do it. And doctors say, I have to check, did you look at this? They're all designed to upcode, all designed to get more money in. If we took out all the billing, forget the billing part of it, and just use medical record information to keep track of patients, it could be a gem of a tool for people. And so I agree, it's value neutral in the sense they're good from it and bad from it. But the bad from it is because of our choice, not because of the nature of electronic records.
Thank you.
Sorry, Peter, I want to bring it back
Please.
to the point of care. So one of the, I think, I mean, I can't begin to, again, thank the panelists for their warm words. I mean, it's phenomenal. But one of the things that I want to highlight about the book is that it has to do with care. And one of the points that I think tries to make is that if you were to set up an electronic medical record system in a healthcare system, and you were to start not from how do we set it up so that we can do better financially, but how do we set it up so that we can support care better, you probably will come up with a different product with some features that will be highlighted and easier to use than others that would actually reflect your primary purpose. Right now, one of the ways, so it used to be that clinicians will call each other, talk to each other, to coordinate the care of a complex patient, that you will talk to the patient, maybe bring them excessively into the office, but talk to the patient or call them up and try to talk to the patient about difficult news, even bad news. Increasingly, we are resorting to just type it into the record, and because the record is available, people will find out that the information has occurred. So we introduce another problem, which is the illusion of communication simply because it's somewhere in the record. And that has also created isolation among health professionals who now essentially are writing letters to no one, because nobody's reading what they're writing, because who's going to go through all the stuff that was added for billing to find that nugget of wisdom, which is now hidden in those records. So all that content with so little information and hides the wisdom of those clinicians and isolates them further, I think furthers burnout.
Peter, I had a.
Please, Jigme.
Yep, thank you. So since we have Victor and John Marty here and Sister Rose, I wanted to talk a little bit on the book. In the book, you talk about cortisone and how we, you call it the world's most effective medicine, and placed by Mayo Clinic for just $1. And after 75 years, it still remains inexpensive and vastly available. And in contrast, when we talk about, think about Frederick Banting, who discovered insulin and refused to put the patent under his name on the patent, and and sold it again for $1. And today, when over 30 million Americans rely on and you being a diabetic doctor, we talk about how this pharmaceutical company price gouging, about $1,400 to $1,500 a month. But then something amazing happened in Minnesota with the Alex Smith Insulin Affordability Act, which was, which went to effect in July. And just hours before the law could even take effect, pharma filed an injunction claiming it violates the Constitution, right? So there's this one hand on one side, and which you talk about, the pharma, right? How do we close that gap? Like, what is the care essence of that within the patient revolution?
I've only been close to the Capitol without having to storm it, outside of the Capitol in Twin Cities. When there was a demonstration with Smith family to talk about Alex Smith and the possibility of it. And it's the only time I've actually given a public speech in that sort of environment. I feel very strongly about the issue of affordable insulin. And your point is well taken. There is a cartoon from the New Yorker, which I have used in my talks, and then of course, like every good cartoon, it happened in reality. So the cartoon shows a boardroom, and the person at the head of the table, the chairman of the board, is saying, "It will save countless lives, but to what end?" And it was clearly arguing for, and then of course, Secretary Azar goes to Congress and is told, "Can you guarantee that the COVID vaccine will be available to everybody?" And then basically says, "Yeah, but if I start putting price controls, what will be the incentive to develop the vaccine? It will save countless lives, but to what end?" And I think we are seeing in different agents, in different economic agents within healthcare, that they have forgotten that corporations were set up for public good. And pharmaceutical companies were great partners of researchers, because they provided the opportunity to bring the insights of the research into practice. We're seeing it with the vaccine deployment, right? The work was done by federally funded biotech, biology researchers forming biotech companies, then joining up with the big pharmaceuticals for scale. And that's a phenomenal model, public-private partnership for public good. It's when we start holding the executives accountable for the performance on the quarterly performance, and then putting that performance on the stock market to be their incentive, the source of their pride, that we distort the decision-making process of those companies, which for the longest time were in the service of the public, the service of the patients. So I think it's not unreasonable to think about a challenge from a legal framework perspective, in which we start asking the government, the state, to say, can you become mission-oriented? Can the government say, look, like we did tried to do with the vaccine, if we're going to make sure that every person with diabetes will have access to insulin like they have access to water, right? I'm just going to make that happen. Okay, challenge accepted. Who can step forward and make it happen? And then we would like to see private-public partnerships that will bring the price of insulin, bring the price of all those things down, and make sure that people can still put them out there and make a good living, but not the exorbitant profit making at the expense of at least anxiety, if not death, of those people who cannot access that medicine. So I think we need a reframe of every aspect of healthcare. And pharmaceutical is just one of them. Devices in Minnesota, which is a strong component of the Minnesota sort of vibe in relation to healthcare, it's another area that needs, the incentive, if the incentive to invent, I don't think sincerely comes from the fact that I'm going to make a killing, which of course nobody should be making a killing in healthcare. It comes from the opportunity to use my ingenuity to save lives, to make lives better. There's no bigger calling. And we just have to make sure that people that do that can have a comfortable life and be rewarded for that. But excessive profits? Why? If the excessive profit takes away the opportunity for people to enjoy that innovation, then it's a betrayal of the spirit of the innovator.
So there continues to be discussion, some very good points about electronic medical records, and I encourage you all to read the chat. Let's see. I'm going to take the privilege of asking a question myself, and I think that it's a challenging question, and that is, where is the momentum going to come from to transform the system? And I think that we're very fortunate tonight that three of our speakers represent different layers of the healthcare system: the doctor, the nurse, the other workers who support the doctors and the nurses in providing care for the patients. And I wonder, how do you see doctors, nurses aides, LPNs, janitors, custodians, other food providers in the hospitals, how do you see the workers in the hospital setting working together to address the issue of how their industry functions? Is that a place to look for momentum in promoting change?
I would like the panelists to also have their
Oh, yes.
So, but I'm just going to briefly say that I do not know where the momentum is going to come. I do not know what is going to be the trigger. We know that when things happen, when fundamental changes occur, that one can only in retrospect see that there was where the tipping point occurred. It's hard to tell when you're at the moment that you've actually, make that. So many times you feel like, oh, this will do it, and then it doesn't, right? I mean, the situation with George Floyd, killing of George Floyd. Okay, so that's going to be I don't know. I mean, might not do anything at the end of the day, or maybe it will keep momentum and it will change fun. We'll get a second era of civil rights, here. I don't know. I can't tell. I do know that this will not come from the industry itself. And I do know that health professionals, because I've asked, last year when I could travel, I've given like over 70 talks, and most of them are to colleagues, and everybody, has the same response. This makes so much sense. We got to be doing this, but I don't know how we're going to change. And I tell them, oh, but your patients think that you have all the power, and then they start looking at each other, like, we don't. And so it's almost like an abused spouse, right? There's this learned helplessness among health professionals that just simply, I think they need organization. I think they need direction. And I don't know that it's going to come internally from clinicians. Could be from a next generation, perhaps, of clinicians. But I really hope it will come from the citizens, because the moment it happens, the citizens care. The thing that inspires me is that picture, from the March of Selma. You see You see Martin Luther King and the other Black leaders at the front line, but they're not, they're not alone. You see all these other Black people at the front, right? And so I think it's going to be the same thing, is that we're going to have, citizens, leading this, but very quickly, all the health professionals that depend on the industry as is are going to realize there's something much better waiting for them after our revolution, and they're going to join them in the front line to change it.
Thank you. Rose?
My question.
Hi, sure.
Hang
So
on, David.
So I think where the momentum comes from is from us, and I say that in this venue, individual clinicians or workers inside of the healthcare system cannot take on industrialized healthcare by themselves. They just can't. There has to be a collective voice, and someone in the chat did mention doctors and nurses organizing into a union together. Hear, hear, brother. I couldn't be more excited about that idea, because I honestly don't know how we begin to take it on unless we are united together. And that it also means to do the organizing outside of the system itself, which is the patients. Every single one of us are patients. At some point in our lives, we need health care. That's just a fact. And so having these kinds of opportunities, Peter, that you provide for these conversations one-on-one with one another, bringing more and more people into the movement to show them hope, to say there is a way that we could do it differently, and we could center patient care and kindness. They want to hear that. Many feel hopeless. They're like, oh my God, it'll never happen, right? I mean, we're up against this bazillion-dollar, giant. And how do we be the David that takes them on? We can be the David. We just have to get together. We have to cross-pollinate in our justice movement, because health is innate to all of us. And it is a part of racial justice. It is a part of poverty justice. It is a part of environmental justice, housing justice. Those are social determinants of health. They all impact health at the end of the day. And so it isn't going to be easy. It isn't going to happen overnight, but this is what will be a catalyst. And I do really think that the pandemic has, as the doctor said, exposed this system for what it is. And I think more and more people are much more open now than they've ever been to having the discussion we're having here tonight.
Great, thank you. Jigme, do you want to add something to this?
Those are amazing. I think, we follow what Rose said and we could get this done, right? I mean, absolutely, that is the reality of it, right? But, the underlying thing about, like, especially being working with healthcare workers for the past 18 years, one thing I've realized is the first step is to acknowledge it, right? Within the system, there's no acknowledgement. I talk to immigrant workers, healthcare workers who are taking care of the most vulnerable people, but unable to be with their parents back home, right? These are the pieces within the system. When we look at it, the system has one of the most diverse group of ethnic, race representation. But when you look at who's on the top healthcare leadership position, it's a handful of people of color, right? These are the issues, like what is the recruitment, what is the trajectory and pathway forward, support, development, and promotion for people who actually are the voices who are facing this crisis, right? And bring them in so that you change the system based on people who are impacted the most.
Thank you. David Yanowski, you had a question you wanted to bring up.
Well, I'm just wondering if there was examples from other countries that we can learn and some good models. I know that we spend 17.1% of our gross domestic product on healthcare, and I can list dozens of countries that spend about 10%, so less 40% less than we do, and yet their results are better. But I don't know if the really kind of care is any better. But are there countries we can emulate and find out some things from, Victor, or any of you?
I actually personally think that is a flawed question, not a question, flawed analysis. I mean, there's a lot of comparative analysis of different healthcare systems in terms of access and in terms of affordability. And just like I think we want care for this patient, not for patients like this, I think we need healthcare for this community, not for communities like this. I think that countries have the healthcare system that were natural, that are consistent with their ethos, with the way that communities built and what inspired, and it changes over time. I mean, the UK, for instance, the NHS will be impossible today, right? Probably since Thatcher, that would be impossible over the last 40 years. It was possible with the post-war solidarity that emerged from having survived the war together and having to rebuild the country. I wonder what other country is going to be in a position of having survived a disaster and having to rebuild it. Perhaps there's an opportunity in that parallel to see what kind of thing will, and I'm actually quite concerned that in the United States, there are multiple countries in this United States. The situation in the South requires, I suspect, a completely different healthcare system than, say, Minnesota. And maybe not in the macro details, but certainly in the kinds of things that the citizens of these different parts of the country are willing and ready to do to care for and about each other. And so to the extent that healthcare reflects the commitment to care of a particular community, it takes a particular shape. And so I don't know that we can do that. I can tell you that we have experiments in different places that we can learn from. And in our organization, the Patient Revolution, patientrevolution.org, we have Patient Revolution fellows. And these fellows have come from all over the world. And so we are trying to gather the best experiences that those people have. One of our fellows, incidentally, until very recently, was a physician representative in the Union of Physicians in Norway. And so she's bringing some of that expertise into our conversation within the Patient Revolution. But we have folks from several parts of Europe, South America, and Asia that are contributing to our thinking, because again, not in every country, but in every place within those countries, there are pockets of care, and they're worth emulating in a way that reflects our local ethos and our local values.
John Marty, please.
Yeah, 2 comments on that, one of which is, in terms of looking at other countries, the one thing I would suggest is that Taiwan, 25 years ago, they decided they were becoming a more industrialized country. They wanted a better healthcare system. They actually sent teams of people around the world to see what worked best and so on, and they plugged it in. And in many ways, they spend, I think there's 6% of their GDP, 6.5% as opposed to our almost 18%. And they have an excellent healthcare system for it. I would argue they should spend a little bit more than the 6%, maybe 7%, and they'd have one of the best in the world. But I do think, yeah, we should be looking for what's the right thing here. And again, there's a comment about we don't have a sustainable means of funding rural healthcare. We need to have different challenges in rural communities than we have in the core cities, different challenges in the immigrant communities and elsewhere. But I think if we design a system that's based around patients and their medical providers, not based around money, and I do think that's possible. The analogy to Taiwan is they said, we're fed up with what we got. And if you want to hear why we should change it, well, because we can do better than this, and because our system's blowing up in our face. We keep trying all these new reforms, half-baked things that are supposed to save money, and we're spending literally twice what the rest of the world spends on healthcare, with maybe 10 exceptions who spend more than half, but far, far less than we do. So no, let's design our own best system the way Taiwan did.
Thank you. Well, I'm tempted to call the end to this, that we don't have more questions coming in. Any of our, let me make one more call. Someone want to pitch a question before we close this down for the evening? We'd said we'd try to give it an hour, a little bit more than that. Or any of our panelists, a last comment?
Yeah, I would like, thanks,
John.
I would like to read one paragraph from one
Great.
chapter of this book, because I
Sure.
think it's important. I mean, everybody's struggling, everybody's suffering. It's a dark time. And we have to recognize that the reason we're passionate about this is because we believe in caring. We believe in care for and about each other as a way out of our own personal miseries, but also as a way out of our communal miseries. Is solidarity and caring for each other. And the book has a chapter on love. And it's always been a struggle because people say, well, what do you talk about love in healthcare? No, there shouldn't be any, people are more embarrassed to talk about love in healthcare than they are about talking about profit in healthcare, which, that should tell you something. But the chapter on love finishes with this paragraph, and I think it's what we need to reflect. That's what healthcare needs to be, is to go to create possibilities of the relationships of love. How is your father? Are the kids still swimming? You look tired. Are you getting enough rest? Her doctor asks, remembering his patient's worries from 3 months ago. The patient loves that her doctor remembers. She feels heard, seen. Invisible connections are formed, others strengthened. She was not sure if she should tell her doctor this, but she's struggling with her oldest son. The doctor leans forward. She lowers her gaze and her voice. He touches her hand. Love, not time, is of the essence. Her son is in trouble. Perhaps her sugars are high because she is worried sick. Go on. Her doctor listens, cares, loves, maybe.
Victor, thank you. That's a beautiful note to end on. Thank you for generating this conversation tonight, giving us an opportunity to bring these perspectives together. Those of you who have been watching, let me say this is going to be available. A video of tonight's conversation will be on our YouTube page and will continue to haunt our Facebook page as well. One of the things that we've learned at the Eastside Freedom Library is that in the period of this pandemic, more people are watching our videos after events have happened than are watching them live. So there's no shame in watching it later or encouraging your family or friends to watch it later on. It's easy to do. If you're not receiving our newsletter, if you're not on our email list, please go to our website and go to Get Involved, click on mailing list and give us your email so we can let you know about what else is going on. I want to thank Carla Reilly for her work putting the technology together, Clarence White for his work in putting this evening together. I want to thank Victor for writing a great book, John Marty, Rose Roach, and Jigme Ugan for sharing their thoughts with us, Dave Unowski for having the idea to even do this. And David, shall I give you the last word? I'm happy to do that, especially since you've muted yourself. There you go.
Yeah, well, I hope everybody will think about buying the book and also look at Victor's website, patientrevolution.org. Thank you all. And thanks for the people who watched and participate. Thank you again. All right.
Thank you, Victor.
Thank you, Jimmy.
Thank you.
Yes, thank you
much.
so much.
Thank you, Victor.
It was
Incredible.
wonderful.
Thank you. Thank you all. I hope our paths cross again and we can do some magic together. That would be lovely.
Absolutely.
Sure, it happens.
We'll make it happen. That's right.
I look forward
We're
to it.
organizers. It'll happen. Good night, everyone.
I look
Thank you.
forward
Good
to
night,
it.
everyone.
Thank you, guys. Take care.
Thank
Bye-bye.
you.